meeting with some people, there were some questions about failed Chiari surgeries and reoperations and risks and so forth. And because that's always, when people are considering surgery, things they want to consider. So I'm going to go over those. We all kind of know this, but surgical treatments, decompression, and the standard surgery is a linear incision in the middle. And I know you all know this. And then we take off the bone in the back and take off C1 or part of C1. And then we determine whether we need to open the covering of the brain or not open the covering of the brain. And we do that with ultrasound during the surgery. And if we don't feel like with ultrasound there's a good enough decompression or CSF flow or enough CSF around the tonsils, then we'll open the covering of the brain. And that's what's shown here. This is opening the covering. These are the tonsils that are going down. There's a lot of different techniques in terms of what to do at this point. Some people will just open the covering, open up the arachnoid, which is another layer here. It's very thin. And then they'll just they'll place a Dura patch. And the type of Dura patch can vary. It can vary from synthetic material, so it's non-human material that's sewn in, or people will use harvested tissue from the patient themselves at the time of the surgery. So it's their own tissue. The other thing that some people then will also consider doing is they will actually look for adhesions that are in here. And that was a talk I was going to give on, and I figured I already kind of talked a little bit about that earlier. I'm going to talk a little bit about here in this talk as well, but not give a whole talk on it. But these adhesions are scarring that occur from the cerebellum and from the tonsils of the cerebellum down to the brainstem, into between the cerebellar tonsils themselves. And it can obstruct the fluid flow out from the fourth ventricle. Oftentimes people will use a dural sealant. That is pretty common. It kind of helps protect your sutured graft in place so you don't get the big issue of a pseudomeningeal or a CSF leak. So this is one of my surgeries. This is the patient's head is up here. They were fixed in pins, and this is down below. This is bottom. This is going down to your back. And this is down to the legs down here, and this is the top of the head here. And this is the incision we take. And then, and this technique I learned from Arnold Meneses, who was here for a long time, as we talked about before, is just using the same incision instead of having to do a separate incision up here for something called pericranium, which a lot of people do. But use the same incision so you don't have to do that, and take covering of your muscle called fascia. And what's so nice, and so here it is, this is fascia, it's separated from the muscle. You can just cut this out and then use that for your patch. The nice thing about this, any kind of tissue from the patient themselves, is that they're not going to reject it. Number one, that it's going to be highly vascularized very quickly, because it will integrate very nicely into the patient's own dura. It's also, both this and pericranium are very sticky. So when you suture it, it's actually kind of difficult to suture because it pulls so much of the tissue through each suture hole. So it really becomes this watertight closure when you're done. This is, we kind of published our series of patients that we had looked at from the opening, the covering of the brain, and looking at all these adhesions. And so when I do this surgery, it is opening the covering of the brain if we need to. And it is taking down all those adhesions and all the scarring that you see. And you're doing that in a very careful way. Some people say, well, you're going to create more scar tissue by doing that. Well, we do it very, meticulously. We do it under a high-powered microscope. The goal is that there's no blood that goes intradurally at all. So everything is cordoned off. You want this to be as pristine as possible. And then the other thing was looking at the fourth ventricle. The goal really of these surgeries is that there's fluid out of the fourth ventricle. And oftentimes there is scarring over the fourth ventricle. And we published this paper showing that there's in patients that have a Chiari with the syrinx, they are more likely to have scarring inside and covering the fourth ventricle than those patients who do not have a syrinx. And this has just kind of been borne out over the years by people showing that opening the covering of the brain in a Chiari is more likely to resolve a syrinx than if you don't do that. So almost all patients that have a syrinx, we will open the covering of the brain and do this and look for these adhesions and coverings and remove those adhesions and coverings so fluid's flowing normally. Not doing this, and I've taken care of now multiple patients that they have not done this, then sometimes the syrinx will not go away, and I will go back and I will open up and I will find, can you play this actually? Yeah. And you'll find this veil. They have a large syrinx still that persists. And you can open this up and you'll see all of a sudden now, oh, look, it's very clear. CSF is flowing normally. So that's a micro scissors, all underneath the microscope. So little scissors cutting this open. These are little adhesions. And fluids, you can see the fluid pulsations now coming out normally, okay? This little, flash every heartbeat. So that's what you want. And then you get your post-op MRI 6 months later, and wow, look, the syrinx is completely decompressed, showing that in some cases you have to do more than just doing a duroplasty. You actually have to look for these adhesions. And this is the whole big picture of this, is the bones removed, and this is the opening here. We take down these adhesions, open things up, and then place that graft. You can see all the stitches that are placed here. And I do these individual stitches so I can get a very good, tight seal. And it's very meticulous to this. So no blood is also goes intradurally here because we don't want any kind of inflammatory material inside. Because the whole goal is to stop scarring, intradural scarring. And any drop of blood, the patients with Chiari, they're just more susceptible to than others. They have a big inflammatory reaction and can produce more scarring from that blood that's there. So this is what you want. This is a patient with Chiari malformation, tonsillar descent. They have a large syrinx. After you do surgery, you want this nice CSF cleft, no more brainstem compression, and that syrinx is gone. So this looks like essentially back to normal. Okay, like someone who has a normal cerebellum, they never had a Chiari malformation before. So what complications can occur with Chiari malformation? So I'm just going to list them all, and we'll go through them separately here. But aseptic meningitis or bacterial meningitis, this is really any kind of infection is the worst complication you can have with Chiari surgery because the infection occurs down here. And patients that get an infection down here, you get scarring. And what I just tell you, the goal is to remove scarring from this surgery. You want to have these CSF pathways open. And so, we'll do surgery up on the top of the head and we'll have a tumor or something we take out and you'll get an infection once in a while, right? It's not common, 1%, 1.5% is the literature. And that's what we see. But that infection at the top of the head, you wash it out and most patients do pretty well. You'd be surprised. And they might have scar tissue at the top of the head, but that's not where the CSF pathways are. So if you get an infection down here, it is so much worse. So they may need another surgery to wash out the infection, another surgery then to treat increased pressure because the scar tissue down here, that's a shunt. You may have to then do another bypass because they're scarred over here so they don't have a syrinx anymore. So you can see these surgeries then wind up more and more and more. That infection can destroy tissue and muscle back here, and these patients are already susceptible to having instability. They wind up having a fusion surgery, and you can see this cascade of events, and subsequently that's why we have conferences like this, right, where patients have had these kind of multiple surgeries, and it is hard not to have one. Everyone's going to have an infection, right, at some point in your career, treating these patients, but it is, so you can't always prevent it, but it's one thing that I always tell patients is number one, right? At some point, you're going to have an infection like that as a surgeon. And just managing those, when it happens, managing the problems that arise. So CSF leak through the incision. So that's the other thing. If you open the covering of the brain, you're at risk of that CSF leak. It can leak out through your graft. It can pull back here. It can leak out through the incision. Again, that's why meticulous closure, using the patient's own tissue, data would suggest that that's better than synthetic because it heals quicker, right? So you're less likely to have a hole that would then allow that fluid to leak out. Hydrocephalus, that's a backup of fluid in the brain, and that can be from different causes. Not common, maybe it's probably less than 1%. And that's after surgery. And then cranioscervical instability, or not recognizing kind of that they have that before surgery. And then after surgery, you have instability. You might have a kyphosis of that area where this part of the skull goes forward. And there you have to have a fusion in the back of the neck, which we talked about the other day. Or then persistent symptoms or worsening symptoms. So may have continued brainstem compression or block of CSF flow or enlarging syrinx or brainstem compression and symptoms. So all those things that would require additional surgery. So aseptic meningitis. So this is non-bacterial meningitis. It's not an infection. And this is usually from the muscle and the myoglobin that you've done your surgery. You open up the covering, that myoglobin, some of that can actually get inside the dura, or some blood products get inside the dura that irritates in these patients who just have a higher inflammatory state. And that can lead to nausea, vomiting, headaches, neck stiffness, fevers even. And this can be persistent and can occur days to weeks after surgery. Really, the treatment course is steroids. Now, to try to prevent this, I place all my patients on steroids after surgery. So if I do intradurally, I do 5 days of steroids. And that does seem to really, really, I think, reduce this, because the incidence of aseptic meningitis in our patients is very low, probably less than 1%. So CSF leak through the skin, this is a CSF leak that goes out through the incision. And that's problematic, right? Because that's where if CSF's leaking out here, bacteria can get in, right? And that can result in meningitis, the scarring, and all those problems. So that needs immediate attention and typically a surgical repair. So CSF leak can also cause a pseudomeningocele. So that's that pocket of fluid in the back of the neck, right? So that's CSF is not coming out through the skin. It's just trapped underneath the skin. Problem is that destroys these muscular attachments. It can lead to instability. It can cause neural compression. Also then cause scarring of the cerebellum to the dura, ultimately surgical failure, and that may need, again, another surgery. I'm going to go through some of these examples, but this is a CSF leak that did not go out through the skin. One thing is some people, surgeons will say, oh, you just don't do anything for a case like this, just watch it. This patient didn't like that answer and came to see me. And I said, well, geez, this is quite large. I mean, there's no muscular attachments here at all. You can kind of see this. So let's try. So we try Diamox and so forth with these patients over time, and that will work in some cases. And you can't really see it that well here, but before, she had a big syrinx before surgery, after before the previous surgeon did their surgery, and the syrinx went away. But you can see what happens afterwards. The Diamox helped reduce CSF production, but then that syrinx came back and it was huge, and then it created this kyphosis in the cervical spine. Ultimately, they required a reoperation, lysis of these adhesions, and then an infusion to stabilize this. And the patient did dramatically better with that. This is another case, again, the patient did not like what they were told, that, hey, I had this big pseudomeningocele, and they just want to watch this. And they had all these symptoms. You can still see the significant brain stem compression and scarring here. And so then this patient underwent additional surgery. So re-exploration of the back part of the brain, opening up the covering of the brain, realignment, and ultimately fusion with her rib graft. So you can see pre-op and post-op much, much better. So hydrocephalus, this is an increase in CSF, the brain fluid in the ventricles after surgery. And postoperatively, hydrocephalus, it can develop weeks after surgery, or just days. It just depends. But often patients will have severe headache, nausea, vomiting. And this oftentimes patients are really they need a ventriculoperitoneal shunt. So that's the shunt that goes from the ventricles, all internalized down to the abdomen. Another complication is craniocervical instability, and that's can be from different causes. So lack of proper muscular closure after surgery. So every layer of muscle we go through, they all meet in the middle, and they get separated. And so we have to stitch them back. And if you don't stitch them back, they will just separate and can pull apart, especially if patients are active. And so that requires a layer by layer closure, anatomic closure, where these muscles all came, where we separated them from the middle to do the surgery, back in the midline. And so this does take some time to do this, especially in people with a significant amount of muscle, but that's critical. If those muscles eventually pull apart, patients will have pretty significant pain in that defect in the midline, and then that can also lead to just instability. And oftentimes the cervical collar will help, and that can also lead to a indication that occipital cervical fusion would benefit those patients if they no longer want to wear a cervical collar all the time. Other things are that these patients can have EDS, connective tissue disorders we talked about. All that can lead to a higher risk of cervical instability after surgery. So this was a patient of mine who had previous surgery and then found to have Marfan syndrome after her father died of a cardiac event. And he was quite young at the time, and they said, this is unusual, and so they did genetic workup of the whole family, and they found to have a genetic mutation similar to Marfan's. They're all had similar appearance. We talked about these patients can be very tall, they have long fingers, long arms, and that's exactly what you saw in her. She's has all of that, and so that kind of helped point things in the right direction. She had this enlarging syrinx and symptoms. This is after initial surgery. Syrinx is smaller, and you can see what happens. Like this has just got more compressed down here, more brainstem compression, and enlarging syrinx, and a larger acute clavicle-canal angle. In this patient with a connective tissue disorder, we went back and did a re-exploration, lysed adhesions, and the syrinx completely went away, or just resolved, essentially, small deflated syrinx here, and then a fusion, and she did fantastic. Again, we talked about this the other day, but this is the same thing. Trying to identify these patients ahead of time is ideal. It's not always the case. Maybe you miss a case like a Marfan's or something like that. That can, especially if they're not like classic connective tissue type patient. But those are things you're trying to identify beforehand. For these bony problems, like getting a CT scan ahead of time, what helps you can look at the MRI and get a better idea. But if you have any of those, those buzzwords of bony problems, those are patients that need to get the CT scan before you do a standard decompression. Talked about that. So my last, one of the other complications, on the last slides here, is Dr. Wilson talked about this on the first day, these dysesthesias after holocord syrinx collapse. So this is an adult, they've had a syrinx their entire life. This whole spinal cord is just filled, right? And the spinal cord is very thin. This is a 30-some-year-old woman. And when we do surgery, you can see tonsils look great now. You have all the CSF cleft, and the syrinx is completely collapsed. So this is not a syrinx. I don't call this a syrinx anymore. This is now a collapsed syrinx. It's just a CSF space now in the spinal cord. There's no distension of the spinal cord. So this is a great success in terms of radiographic appearance. And then you're saving this patient then from having persistent muscle atrophy, weakness, so ultimately would be spasticity, and eventually could lead to just being in a wheelchair for life. However, these patients are at risk for developing new types of symptoms, and sensory symptoms, so neuropathic type pain or sensory disturbances. And these are patients that are usually, when the syrinx collapses like that after surgery, the numbness, paresthesia, weakness, dysesthesia, etc. The highest risk are those with those very dilated holocord syrinx, okay? And that is where the whole cord has a syrinx, and it's just all the way out to the spinal canal. And they probably had that for decades, and symptoms were just kind of missed and such. Less likely in kids. I don't see this as much in kids where they have a large syrinx. Teenagers, just because they haven't had this for that long. These are most common in adults. And sometimes you try to treat with neuropathic pain meds, gabapentin, Neuron, Lyrica, and so forth. And the pain talks that you heard, sometimes that does not work, unfortunately. And they have this new pain they haven't had before, and it can be very severe. And so for those patients are seen in the pain clinic, and Dr. Rastogi, who talked yesterday, we'll go through the whole kind of treatment algorithm to see what he can do to help. So thank you. I'll take any questions.
What do you recommend for a patient that is a year post-Chiari surgery, 3 months post-op, they had a CSF leak. The leak was repaired and a shunt was put in, and now they feel like they have too low of CSF in the brain. The doctor recommends leaving the shunt in to not cause the leak to come back.
Treating these like post-op complications are challenging, right? And in every case is a little bit different. I can't. It's hard to answer that question, obviously, without seeing imaging, and such. But in general, when you put a shunt in, everyone's worried about taking it out, right? Because are you just going to fail? Is it patient will still have, maybe they have hydrocephalus, or now, and so then you're dependent on the shunt, and so. That can be worked up, but usually you would give it more time than just say 3 months after doing the shunt or doing after that initial surgery. That'd be something maybe you consider like a year out or something down the road to explore, 2 years out or something, where someone says, can we get rid of the shunt? There's also programmable shunt valves that you can dial the shunt up so you're not draining as much CSF. So if that was done, you can change the shunt valve. That can help. Or if someone's just over draining because of the siphoning effect, which all those shunts will have an anti-siphon component to them, they are not perfect, okay? They still siphon. But additional anti-siphon devices can be added to distal to the valve and the shunt tubing, and then that will help to decrease the amount of that siphoning effect and then preventing over drainage. So it's different strategies in terms of treating hydrocephalus or over drainage with managing the type of shunt or adding an anti-siphon type device, an additional one. Oftentimes these valves will come with an anti-siphon device, but it's not perfect, but adding one distally to that can also help. So those are the thoughts behind that. Other questions? Yep.
Eric.
Hi. What's your take on if someone gets a bovine implant for the Chiari surgery?
Yeah. I know many people will do bovine, right? It's called DuraPair. It's like the most common, and they do fantastic. Okay. There is some studies, more recent literature, that suggests maybe this is from pediatric Chiaris, that maybe less risk of a CSF leak, okay, with the patient's own tissue being used. So, if you haven't had a CSF leak and you had bovine and you're doing great, then there's no issue, right? But many patients get bovine, and it's fine. Other questions?
Hi. Do you have special techniques that you use to decrease scarring in patients who have EDS?
You mean decrease like on the skin or closure? Okay. So there's a couple of things. So I'm just going to come back to the question about the bovine, right? So bovines used. Why I don't use the bovines, because I feel like, I think that patient's own tissue is always better. And that's my surgical preference. And I've used DuraPair before, and I just feel like with my technique, I get a way better closure with the patient's own tissue. And I just like, it is, to me, night and day. There are probably people that have probably some other good technique with bovine that they can get some great closure with it. But for me, their patient's own tissue has been tremendous. In terms of like this reducing scarring, for all surgeries, the goal is that there is absolutely no blood that goes into the intradural component. So, we work with residents, and so that's the number one goal. I tell them they're gonna suction, and they prevent if they see any blood, and we cordon everything off with patties and such. And that's true for everybody, even patients with any kind of connective tissue disorder. So that helps. Okay. We use steroids after surgery, helps reduce inflammation for about 5 days. With patients with EDS or, again, hypermobility, then the closure of the tissue is important. Okay. And managing that's more important, because they're more likely to separate. Okay. The muscles and the skin even. Okay. But I worry a lot with the muscle. And so then I use a certain type of suture to close the muscles. And I don't close it. I close it, tight, not too tight. Okay. So this is all my nuanced gestalt of how I do it. A lot of stitches go in to close the muscles in everybody, but it's really a particular attention with patients with connective tissue disorder. And then afterwards, I will leave. It just depends on how mobile things feel intraoperatively. Some patients aren't that mobile at that junction. Okay. And I'm like, well, okay, if patients are too mobile, then I will leave them in a cervical collar for about 6 weeks, so that things can really, really scar down and heal well, and heal normally, not over-scar intradurally. Okay. Other questions?
I have a question.
Yep.
Sorry. At lunch, we had some good table talk, and some of the patients were wondering about limitations with individuals that have Chiari, even if they didn't have a decompression. Because some doctors have said, some of their neurosurgeons and stuff back home have said, no heavy lifting, no playing any kind of sport, things like that. So can you let us know if there's some limitations post-surgery or just with Chiari, and as well as Syringomyelia? Some people in here just have the Syrinx.
Yeah, I think that is an individual.
Okay.
That's how I do it now. I used to have all right, no one can do contact sports like football, wrestling, hockey, or trampoline, roller coasters. But some patients come back and their decompression is so good and they're doing so well, and I have a hard time imagining they're ever going to have much of an issue with scarring. And then dealing with the pediatric population, there are just some of them, they're great at sports, and female wrestling actually in Iowa has just become so big, and so I have so many patients. And with Chiari being more common in women than men, I had recently a girl who was just an athlete and wanted to do wrestling, and hers was so good and everything closure would look so good that I let her go back to wrestle. That is not common though. Okay, her skin was just very pristine. And I thought the risk was small. She'd already done things beyond what I was doing. It was doing fine. So I said, okay, you can go ahead. But I think that's an individual discussion with your surgeon. There is data out there that shows, the risk with Chiari, whether not having decompression or not, doesn't really increase your risk of sports injuries. The problem with some of these studies is that it's not taking individual into account. Like if you have severe brainstem compression, a big syrinx, you're probably going to be at a higher risk of having a sports injury, especially if you're doing contact sports. But those studies don't look at that. It's not that granular to look at it. They're just saying overall, which is probably true overall. But those individual cases are the cases that you have to speak with your doctor about. Yep, go ahead.
I've seen several comments on the Facebook pages for ASAP of patients mentioning stroke after PFD. Can you speak to the risk of that?
That is not common. Okay, I do know that someone in one of these, I know another very experienced neurosurgeon doing Chiari surgery, spoke 2 years ago at a conference, and he said which I never knew was possible, but he had a patient with more of a bony issue, retroflex dontoid, and he wasn't going to do a fusion. So he flexed the neck at the time of surgery, and after surgery had a brainstem infarct because of compression from the bone on the brainstem. But that's a unique case because they had a bony problem, and so then he says, what should I have done differently? Should I have done a fusion? Should I have done neuromonitoring? So there's risk of that. That's not zero, of course, but it's not common. Okay. There are vessels. You see the vessels that we are in when you see the OR pictures, right? We do encounter those, but I think a risk of a stroke and doing Chiari surgery probably is less than 1%.
Yeah, question. So in case the second surgery is needed to remove adhesions or, scenario when syrinx is not going away, what is that second surgery? What is recovery time? Is there any additional risks with that? What to expect?
I think the second surgery, most patients recover the same. If you're having to have a redo, I guess it depends on what you're doing, right? A fusion obviously it will be longer, right? Recovery, because it's a bigger operation and such. It's not going to be weeks longer, but a couple more days, right? In terms of in the hospital and then, even at home and such. But the surgery is, again, trying to open up that fourth ventricle, right? To get the CSF to flow normally. So it depends on what's done initially at the first time, but it's going through the same incision. You're not going through a different incision, you're going through the same incision, and seeing if you can remove some of that scar tissue.